Okay, this is a nice topic. Discusses, it's kind of a review of how we can get towards cleaner air and better health, the current state, challenges, and priorities. A nice little article which I'm going to, introduce very briefly as usual. You definitely want to go and read the article and follow up on the nice long list of references if you are interested in this topic and more details and so on. Okay, so came out in Science just this few months ago. The most up-to-date estimate of the global burden of diseases indicates that ambient air pollution, including fine particulate matter and ozone, contributes to an estimated 5.2 million deaths each year. 5.2 million deaths each year. In this, usually they mean premature death. In this review, we highlight the challenges in estimating population exposure to air pollution and attributable health risks, particularly in low and middle income countries and among vulnerable populations. To protect public health, the evidence so far confirms urgent needs to prioritize interdisciplinary research on air pollution exposure and risk assessment, and to develop evidence-based intervention policies and risk communication strategies. Here we synthesize the emerging evidence supporting the monitoring and evaluation of the progress in implementation of the global air quality guidelines prepared by the World Health Organization. So the topic is not new, but review means you are putting together the synthesis of all that we know so far. Obviously, we are all aware of what natural and anthropogenic emissions are: particulate matter 2.5, PM10, ozone, NO2, NOx, carbon monoxide, sulfur dioxide, volatile organic compounds, sulfate, nitrate, ammonia, black carbon, UFPs, polyaromatic halocarbons, dust, CFCs, heavy metals, methane, and so on. So air pollutant emission sources, detrimental lifespan, health impacts, and personal level risk mitigation. So give me a second, I have to respond to this, unfortunately, while I'm recording. Urgent. Okay, so yeah. So aircraft, biomass burning, residential sector, shipping, of course, wildfires have really been putting out a lot of ultrafine particles, PM 2.5, and a bunch of other chemicals. Cattle, of course, produce methane, and agricultural pollution is not trivial. Ground transportation, volcanic eruptions, and industrial activities. In terms of outcomes and personal exposure mitigation, outcomes include pregnancy and birth, so term low birth weight, preterm delivery, spontaneous abortion, infertility. So these are all studies that have found a connection between natural and anthropogenic emissions and these outcomes. Children, of course, asthma onset, acute lower respiratory infections, neurodevelopment disorders, and among adults and elderly, you have central nervous system, respiratory, cardiovascular, metabolic disorders, cancer, kidney, genitourinary, immune and allergic. So personal exposure mitigation, just as a completeness here, wear a respirator. So air pollution should be easy to deal with a respirator, but of course there's the issue of affordability. Plus, if you're working outside in hot, humid air, it can be incredibly uncomfortable to wear a mask or a respirator on top. Okay, so stay indoors. Can you really afford to do that? But it's a good mitigation. Use air purifiers. Can be very expensive, but people can afford it, then they are obviously safer. Avoid polluted areas. Okay, so again, do you have a choice? If you are a worker, a vendor, a taxi driver, a bus driver, or whatever, can you really stay indoors and so on? Global levels and trends of population weighted annual average ambient PM 2.5 shown here, and seasonal 8-hour maximum ozone concentration here from 1990 to 2019. Obviously, this is a very region-specific, location-specific loading, but here we are taking global levels just to get a sense of the regional disparities. PM 2.5 estimates were derived by combining data from 10,408 ground-based air quality monitors representing urban and rural data in 116 countries around the globe. So fairly representative sample with good spatial resolution, as well as exposure estimates from satellite observations and global chemical transport models. Ozone exposure estimates were derived by combining data from 8,800 ground-based air quality monitors and chemical transport models. So just to tell you that this is a serious amount of data going in, doesn't mean it's enough. You need much more data because pollution is hyper local. Even in a city, some neighborhoods have very different loads of these pollutants than others. So annual population weighted PM 2.5 in micrograms per meter cube from 1990 to 2019. Here is the WHO air quality guideline value of annual average PM 2.5 in microgram per meter cube. It used to be around 12, they have lowered it to 5, but you can see that all regions of the world are above it, some are way above it. So Central Europe, Eastern Europe and Central Asia, so that's somewhere here. High income countries are doing better here. There is some detail on why this is dashed, but you can go and look it up. And of course South Asia is way up here, which includes India, Pakistan, Bangladesh, Nepal, Bhutan, Sri Lanka and so on, Burma. Okay, and this is about ozone, and again ozone WHO standard is here in 8-hour max microgram per meter cube, whereas seasonal population weighted 8-hour max ozone in micrograms per meter cube is up here. So this is seasonal and this is annual, just remember that. So again South Asia has gone way through the roof in the recent couple of decades. There are others, North Africa and Middle East, which all club together here, but it's up here. And then again at the bottom you have Latin America. Well, Latin America, Caribbean is here. This color here is sub-Saharan Africa. Okay, so you can see that it's a very regional problem, even though there are chemical transports, depends on concentrations, residence times, direction of the winds, seasonality, local heating, cooling, humidity, etc., right, and human contributions. So this is about sex and age stratification of the global burden of death attributed to ambient PM 2.5 exposure in 2021, and the death burden attributed to emissions sources of PM 2.5 exposure from different sectors in 2019. So females tend to have much worse in terms of exposure. So this is PM 2.5. Chronic so there are outcomes involved and the age groups involved. Obviously older people tend to be more vulnerable than the younger ones. Here this is going from 54 and above, okay, and this is different regions I'll come to in a minute. Chronic obstructive pulmonary diseases, diabetes mellitus, ischemic heart disease, lower respiratory infections, neonatal preterm birth, stroke, total cancers, upper respiratory infections. So you can see the bad news there in terms of deaths per 100,000. This is also deaths per 100,000, but now we are looking at the death burden attributed to emission sources from different sectors, South Asia, East, for different regions. So you have transport, commercial, industry, energy, agriculture, fires, combustion, agricultural waste burning, wind-blown dust, acid test, that I'm not going to go into that. Remaining sources, solvents, waste, residential and international shipping. So you can see how they add up over Southeast Asia, East Asia and Oceania. Stands at the highest Central Europe, Eastern Europe, Central Asia is the second, South Asia, North Africa and the Middle East, Latin America, Caribbean, high-income countries, and Sub-Saharan Africa. Of course, population concentrations, exposure includes population densities and so on as well. To read off a few points about risk communication that we mentioned before, health interventions and risk communications, many jurisdictions have been actively attempting to improve air quality. The most efficient interventions involve reducing ambient pollutant concentrations coupled with communicating the risks to government and to stakeholders. Many policies have been implemented by governments or are underway across large geographic scales for abating population exposure through, for example, smokestack controls on power plants and large industries, tailpipe controls on motor vehicles, promotion of public transport and non-motorized transport, electrification of homes and businesses, and promotion of good practices in agriculture, farming, among others. As for communication for the public and individuals at high risk on high air pollution days, the classical public health message is to stay indoors and or reduce physical activity. However, these responses may not be feasible or even advisable. You may be a diabetic who needs some activity, or you may be working outside. Placing the responsibility for reducing exposure to air pollution on individuals also raises important issues of socioeconomic inequity, which makes personalized responses to access clean air challenging. So if you are not rich, you may be not only working outside, you may also be traveling by public transportation or walking, bicycling or whatever. The cost of air filter replacement is one direct cause of inequity as well. Furthermore, although small-scale intervention studies have shown moderate to large reductions of nearly 11 to 82% in PM2.5 concentrations indoors from use of air filter, so I'm not emphasizing it correctly. Furthermore, although small-scale intervention studies have shown moderate to large reductions of nearly 11 to 82% in PM2.5 concentrations indoors from use of air filters, the outcomes for cardiorespiratory health endpoints are highly heterogeneous. It's kind of a long, clumsy sentence, but you get the idea that indoor concentrations can be dealt with air filters, which have beneficial reductions in cardiorespiratory health endpoints. Okay, but the data is very heterogeneous, or the exposures are very heterogeneous. So, intervention data is very heterogeneous. What are the research and policy priorities? Although we know that air pollution exposure can exacerbate the disease burden in people of all ages, the research and policy challenges remain huge, and priorities must be established to track progress on risk mitigation, intervention, and communication. Globally, the mixture of air pollutants and sources differ across time and space, which can alter the effectiveness of the most appropriate control measures. This variability requires region-specific research. For example, in China, implementation of a tough clean air policy has brought about reductions in emissions by fuel switching, closing down facilities, and electrification. Although air pollution shows large spatial and temporal differences, most harm originates in emissions from traffic, industry, power generation, and domestic sources in urban areas, and these sources should be prioritized. However, policy and implementation of emission controls is complex, especially when considering secondary pollutants such as ozone and the heterogeneous components of PM2.5. Abatement of precursor compounds such as NO2 at different proportions and under specific meteorological settings might be challenging. For example, although emerging evidence indicates that reducing the number of older and more polluting vehicles by London's ultra-low emission zone is associated with reduced exhaust emissions and improved air quality, there are as yet no clear patterns of health benefits. So obviously it takes time. So we're talking about time scales as well. Plus, if there is a transient population, then tracking will be difficult in terms of health outcomes and exposures. Interventions, accountability approaches involving surrogate and hard clinical outcomes are urgently needed to assess the health benefits of air quality regulations implemented in cities and to establish whether such interventions can be effective in preventing adverse health consequences. Determining the chemical properties and biological effects of air pollution from various sources, such as its toxicity, exposure pathways, and associated biomarkers, is important to characterize the populations at the highest risk from air pollution. Multi-exposure studies are urgently required to explore the additive and synergistic effects of multiple environmental factors on individual and lifetime air pollution exposure. Okay? Potential risks from air pollution always needs timely communication at scales among public, private, and governmental stakeholders to prioritize the activities that minimize the generation of air pollution and prevent its distribution through the environment. All these have actions needed behind them, incentives, providing free public transportation or providing time off during the peak heat and pollutant hours to outdoor workers, and so on and so forth. Conclusions then: epidemiological and mechanistic evidence for the harmful effects of air pollution continues to grow, confirming the urgent needs to develop and implement evidence-based air quality policies for protecting public health. To protect the public, several research and policy priorities have already been identified for air pollution, emission control and exposure abatement, risk mitigation for populations at high risk, evidence-based intervention policies, and risk communication strategies. Nevertheless, the challenges in implementing air quality management policies and seeing the resulting benefits to health are huge, particularly in low and middle income countries. So obviously it's often about resources, whether people have the money. Even if you have a lot of rules in the book, is there really enforcement? Is there corruption involved that ignores implementation and enforcement, and so on? Plus, there are inequalities also in terms of where the dirty power plants are put, where the wastewater treatments may be put, which produce all kind of air pollution as well, chemicals and aerosolized other issues. So it's a complicated issue, but at least kind of a brief review tells you that there are pathways to accomplishing these despite the challenges. Okay, so let me leave it here.